Thanks, Jim. Well, I have the pleasure of introducing a fellow Gates Foundation alum who I wasn't paying attention before would be here, and that's Clint Pecenka, who was at the Gates Foundation. Before that, he did a PhD in economics and a master's in public policy at the University of Minnesota. He worked at the Federal Reserve for a while in Minnesota and also taught at Carleton, and then joined us at the Gates Foundation while we overlapped, I think probably for most of our respective time, where he worked with the Central Policy, I don't even remember exactly the name of what it was called, Development Policy and Finance Team. And then about 5 years ago left to join PATH, the Program for Appropriate Technologies in Health. And I would tell you what he's doing there, but he's going to talk about that. So with that, Clint, welcome.
My name's Clint Pecenka, and I'm Director of Health Economics and Outcomes Research at PATH. And I'm going to talk a bit about efficiency and intervention design, or at least how we view efficiency and intervention design at PATH. So a quick overview of what I'm going to talk about. I'm going to talk a little bit about PATH and the Center for Vaccine Innovation and Access, which is the group that I work within. And this might seem like a little bit of an infomercial, and that's really not my intent. It's really to give you context for the work that we're doing because it has implications for the rest of my presentation. I'm then going to move on to talk a little bit about value propositions and intervention design. And some of the previous speakers talked about investment cases, and that's really another way to think about this. So if you can sort of link that in your head, this is everywhere? Yes, it is everywhere, and I'm telling you about it today. I'm going to then talk a little bit about a few products that PATH is developing, and that's going to be something along the lines of contraceptives. I'm going to talk a little bit about cervical cancer screening, and then I'm going to talk a bit more about a new rotavirus vaccine, which is the area in which I work, so I'll spend a bit more time on that. And then finally, I'll spend my last slide talking a little bit about what works well and what works less well in the way we approach this. So here's the infomercial part. We're a global team of innovators working to eliminate health inequities so people in communities and economies can thrive. Basically, we're a big global health nonprofit based in Seattle, and we primarily work on interventions that affect women and children in low and middle income countries. This slide is, I think, a little bit of what makes PATH unique in that we specialize in designing, developing, and scaling solutions in a few different areas. And I'll talk just a touch about this, but I think the part that makes PATH unique is that we're end-to-end. We work at the very beginning to help think about how to design an intervention. We work with industry, and then we work all the way through the process until a product is introduced, and then scaled, and then even wound down in some cases. So I think that gives us a unique view of how this actually works from end to end. There are lots of other partners that do certain components of this, but there aren't so many that play the broad-reaching role that PATH does. We work across 5 different areas: vaccines, which is where I work, and then we also have programs in diagnostics, drugs, devices, and health systems. Within our vaccine space, we have a lot of systems work, but then we also have antigen-specific work, so work on specific vaccines. And that work takes place within PATH's Center for Vaccine Innovation and Access, and that's referred to as CVIA. So I'll try to continue speaking about the full acronym, but it's very easy for me to just say CVIA, so if you hear that, that's what that means. We work across a number of different disease areas: enteric and diarrheal diseases, malaria, respiratory infections and maternal immunization, and then our zoonotic emergency and STI areas. I do want to call out the malaria stuff because that's been in the news a little bit lately. Some of you might have seen that 2 countries in Africa are now vaccinating with a malaria vaccine that PATH helped develop, and something we're pretty excited about, and we'll be interested to see how that plays out over the coming years. Our work really spans, as I said earlier, the entire development to delivery platform. And it starts at discovery, and I'm not going to go through all the small text here. It's just to give you a sense of what this means. But really thinking early, what might promising interventions look like? Moving on to phase 1, phase 2, even phase 3. And then we start moving into pilot and launch, which is the area that I'd like to talk about more because that's the area that I know. Where evidence-based decision-making and much of the stuff that we've been talking about at this conference takes place. We also support countries on planning, preparation, and introduction of these vaccines. And then to some of the discussion earlier in the day, after an intervention is introduced, we also like to spend time thinking about what went well, what didn't go well. How can we improve the implementation and the management of this? So PATH does work across all these different areas, but this is really the model that we have now. So prior to this, in the pre-CVIA world, there's this wall. So you can see these images I stole off the internet, which aren't entirely clear, but we have a whole bunch of our colleagues who work to develop new vaccines. And I don't even know what these guys do, right? They use all sorts of language that I don't really understand and use words that just don't make sense to me. But there are a whole bunch of those guys. And what they would do in the past is these vaccine development colleagues would just develop these vaccines, and then there'd be this wall, and we joke that they just throw the vaccine over the wall, and it was our job to do something with it. And we had some success with that model, but it wasn't ideal for a variety of ways. So we didn't always know what we were going to get. We didn't know when we were going to get it. It was just sort of like, here you go, do something with it. And that's not an ideal way to work. So what we want to do, I know a lot of people these days, or one person in particular talks about building walls, but I think within Sevilla, we were talking a lot about tearing down these walls, right? Because we think that's a better way to work within our organization and maybe beyond that as well. So what's the rationale? I mean, the basic premise is we want to get people sharing information, upstream colleagues talking to downstream colleagues, and making sure that the interventions that we're developing are things that people really want and they're going to use. So we think that's going to improve communication. It's going to make us all work better. Put another way, we really need to figure out what people want and how we get them what they want. So I don't know if many of you remember Crystal Pepsi. So I feel a little bad saying this, but this is my healthy drink up here. This Crystal Pepsi was developed for not really a good reason, right? It's sort of a product in search of a market. And this healthy drink that I have here, which is not Crystal Pepsi, unfortunately, was developed because maybe it was a bit more healthy than regular Pepsi, or maybe it was just like sort of neat and people wanted clear Pepsi. Like, they didn't really know. You read up on this, you read up about biggest product failures, which is a great way to sort of waste an hour of your life. You find lots of interesting things, but the main premise of Crystal Pepsi is they developed it without really knowing why. What's the market need that they're trying to meet? And what I'm trying to say is we don't want to do that in global health. We want to develop interventions that people really need and will actually use. So how do you do that? Well, there are lots of different things that you can do, but what we're doing within the Center for Vaccine Innovation and Access is really developing value propositions for everything in our portfolio. And I'll talk a little bit more about what that means, but at its core, it's just aligning very early on what you want the intervention to do and how it's going to benefit the people that you're trying to help. So these value propositions really articulate the public health benefit of a vaccine candidate for developers, that is the industry and people at PATH who are trying to work on this. It also helps global, be it the World Health Organization, Gavi, donors like the Gates Foundation, and even country stakeholders align on what it is we're trying to accomplish. It also helps define the relationship between the unmet need and the attributes of the intervention. So at its core, or not at its core, but what it really is in the end, it's a big report. And it's a big report that talks about, are we going to reduce incidence of disease, reduce mortality? Are we going to cut down on antimicrobial resistance? Are there social and economic benefits? Or are there protections against financial risk or equity? Is that an issue? Is that important for this intervention? Is it accessible or feasible? Or are there market considerations? Are you developing a product where 10 other products already exist? Like, will this fly? So essentially, it's a big report to help you answer these questions. And a vaccine might do many of these important things on this list, but if you can't tell me the one thing that this vaccine is really supposed to achieve, then that might mean it's not going to be successful. It might be your Crystal Pepsi. It might be something that's kind of cool that's going to be on the shelves for 2 years when I'm 9 years old, and then I'll never see it again. And that's really not what we want. So I'm going to shift gears here a little bit and talk a bit about a couple of interventions that PATH has helped to develop. And I'm going to discourage questions along these lines because I work on vaccines. So I'm just going to refer to others if there are questions. So just fair warning on that. The first of these is contraceptive injections. So right now, the way this works often is there are injectable contraceptives, but these often require healthcare visits. And for various reasons, women may not be able to make it to the clinic. They might not want to go to the clinic. It might not be accessible. So PATH has been working to develop Cyanopress, which is a self-administered injection. It's still in process. They're learning things as they go along, but it's something that the self-administration part is what I'm trying to draw out here. That's what people seem to be demanding is, can we do this at home? Another example of this is cervical cancer screening. So again, for this to happen, women often go into the facility. There's visual inspection, lack of privacy, and PATH has been developing an HPV DNA test to enable self-testing through a swab. So in both of these instances, the real push for these interventions is to promote self-care, and to improve privacy. Those are things that our work has told us that people want. So all of this has been developed through human-centered design, and that's a key component of how they've understood what these needs are. It's not exactly the same thing as a value proposition, but the thing that links them is a desire to ensure that we're meeting the needs of the people that we care about. So switching gears to rotavirus disease. It's always nice to come back home because I just like talking about poop. So that's always fun. So the downside of talking about poop is that rotavirus diarrhea does kill about 200,000 kids a year. Vaccination is typically viewed as the most effective and often the most cost-effective way to prevent rotavirus. And approximately 100 countries around the world, those in green, are utilizing rotavirus vaccines either in national programs or subnationally. There are currently 4 pre-qualified rotavirus vaccines, and in shorthand, that means they can be sold internationally. These vaccines have a lot of great attributes, but there are 2 critiques that typically come out. One is that they have moderate efficacy in high burden settings, and the second is sometimes they're costly for countries who might not be receiving support from Gavi, especially in lower middle income settings. So PATH is involved in developing a new rotavirus vaccine. So the question is, what's the value proposition, or why are we doing this? Well, one potential answer to that question is, well, the Gates Foundation gave us some money to do it, so okay, well, that's workable. What about demonstrating higher efficacy in high burden settings? Maybe that's what we're after. Is it to lower the cost? Maybe, yeah, it's costly for countries. That's something to consider. Maybe it's a new vaccination strategy. Maybe we're going to add another dose to the series to boost immunity. Or maybe we're going to co-administer with another vaccine. Or maybe we're going to develop a combination vaccine so you can give kids protection from rotavirus. Well, they don't even know they're not getting an additional shot. It's just sort of packaged with something they're already taking. So that's maybe nice. Maybe it's to reduce the risk of intussusception, which is essentially folding over of your intestine and often resulting in surgery. Maybe it's to do all of these things. And it's great if we can do all of these things, right? But the answer to this question, why are we really doing it, matters because it affects how you design your clinical trial. It affects the cost of that trial. It affects the timelines. It affects all these things. So if you can't tell me the one reason why you're after this, it's not going to be an efficient way to design an intervention. So let's break this down just a bit more. Are we here to demonstrate higher efficacy? Yeah, that's really what it's going to come down to. And we're going to look at this in a clinical trial. They're going to be starting the phase 3 study in the coming months. Is it about lower cost? Well, maybe. Yeah, I think that's something that people are interested in, but how much lower matters? This is something that still needs to be assessed through the value proposition. Is it a new vaccination strategy? Well, we've determined so far through the research that we've done, it's not about the booster dose. If you give a kid a vaccine for rotavirus at 9 months of age, a good portion of the burden is already behind them. So that's really not going to save many lives. And if that's your intention, which it is, a booster is not the way to go. Can you co-administer with another rotavirus vaccine? Maybe. We're going to be asking people in countries, what do you think about this? Healthcare worker, do you want to give one rotavirus vaccine and at the next visit give another? Or is that too confusing? What do you guys think of that? Is it going to be usable and feasible in country? Is it about a combination vaccine? Well, that's a long-term goal, right? If you can get the same immunity without having to have another contact with the health system or do an additional service at a visit, that's a great thing. But in order to do that, you probably have to develop a standalone product first. What about this intussusception business? Well, this is important. It's been a big problem as far as perception is concerned. But if you look at the data, it turns out the risk-benefit is a factor of 500 to 1. So yes, this is something to be aware of, but if you don't vaccinate with rotavirus across low and middle income countries, you're far worse off in terms of preventing mortality than if you do. So this is an issue, but this isn't the focus of what this vaccine is about. So can we do all of the above? Well, it's great if we do, but all of that isn't critical. So what is really critical? So it comes down to one thing, and I already let the cat out of the bag, and that is we really want to develop a more efficacious standalone vaccine for high burden settings. That's the essential value. If we can lower the cost, if we can develop new vaccination strategies or combination approaches, that's great, but that's further along a critical path. We really need to focus our efforts right now on what's going to get us to our immediate goal, and that's a more efficacious vaccine for these low or high burden settings. So we are continuing to conduct some of this work. economic modeling, feasibility research, all of that's going to be taking place for the next couple of years. And what I think we'll find is that we learn things along the way. So the vaccine that we envision today probably isn't going to be exactly the vaccine that's out there in, say, 3 to 5 years. However, it's probably going to be a better vaccine because of what we learned through this value proposition. So now I'm going to shift over a bit to what works. We start to focus earlier on user needs, and that focuses our effort on critical product attributes. Just to give you an example, you start bringing introduction or implementation people into the room, and they're probably going to have some ideas that the vaccine development guys haven't thought of. Vaccine development people are pretty smart, but they're not always thinking about the end use. And in the big picture, yes, they are. And I don't think I'm saying anything that's rocket science, right? But we all sort of default to our own disciplinary biases at the end of the day. So if we can get people to remind the vaccine development folks that, hey, you know, somebody's actually got to use this at the end of the day, it actually makes the design better. Sometimes value propositions alter global stakeholder views in clinical trial plans. It doesn't always happen. In some sense, it's 2 steps forward, 2 steps back. But we have had some success in really aligning our trial designs around what the value proposition tells us the critical value is. We can eliminate these nice solutions, the Crystal Pepsis that are sort of nifty and they show up on the shelves every 15 years just so Pepsi has a new marketing strategy or something. But it's not something that's going to be a long-standing product, and we want to avoid that. So what doesn't work? Well, I end up in a lot more meetings, and I don't like that. It is important because we start to take introduction perspectives into the vaccine development process, but it also ends up with us spending a lot more time talking to each other instead of sitting down being an economist, and that's sort of where I like to spend my time. That's sort of facetious, but at the same time, it does add sort of cost of management to the overall vaccine development program. It's not a perfect tool. Sometimes you take 2 steps forward and 1 step back. It doesn't always align people on what we're trying to do. Third bullet from on the or not is user needs might change over time, or you might learn things over time. So again, it could be 2 steps forward, 1 step back. It's all about a process of learning about what the best intervention design could be. And then finally, and I'll close on this point, is if you're a health economist working on a value proposition and you show someone with a really cool idea that it's not cost effective, it doesn't make you very popular. And that means you don't get invited to the best happy hours. So really that's what global health is all about. So with that, I'll close and happy to take any questions about value propositions at PATH.
Thanks very much. My name is Doug Owens, and so we did some work long ago on cost-effectiveness modeling on HIV vaccines. There were none, of course, and the sort of point of that was we showed that even what would be traditionally a failure as a vaccine with 30 or 40% effectiveness would have humongous health and economic benefits. And I'm really very convinced that that work had absolutely zero impact. And so I'm wondering, you know, how are you able to get to the vaccine development people to kind of, you have an integrated model, which is great, but how do you get them to sort of listen to the kind of things that you're doing in your value proposition? And have you had any influence on people, vaccine developers who are not sort of embedded with you in PATH?
Have I had I think the first question is, have we had success in using cost effectiveness analyses to influence design? And I'll point to something that happened a few years ago, and it was around a diagnostics product, and it was around elimination. And it was the sort of thing where using the diagnostic really didn't change your treatment strategy because you either obviously needed to use the intervention or obviously didn't. So having a diagnostic didn't help. So people wanted it, but we sort of delivered that news to the team and it didn't make us very popular. It still continued. So do we always have success? No, not at all. Do we ever change people's views? And a recent example, which I sort of gave here, is around this booster dose. So the Gates Foundation is our donor for this non-replicating rotavirus vaccine. And we presented them evidence this booster dose isn't going to change your overall impact, or it will, but it's very marginal, right? So should you be putting a couple $1 million into this arm of this trial? And they said no. So do we always have success? No, 2 steps forward, 1 step back. But I do believe that we are making progress. And I think, especially at the country level, especially these lower middle income countries that don't have as much access to international financial support, they're very interested in cost effectiveness and even more interested in budget impact. So if you can help them, there's a lot of benefit to that, I think. Other questions? Jim?
I have two questions that's pretty much unrelated. Number one, do you have any evidence yet that this new approach, which brings down the wall, is leading to fewer late abandoned efforts? That's number one. And number two is presumably Crystal Pepsi thought that once they got their product out there, it would develop a following. And it's just, there are certainly some products that we didn't know we wanted until we saw them. Is there any place for that kind of thinking in the health field, that, you know, that you can't really properly prospectively assess demand because it's such a transformative idea that people can't relate to it until they see it?
I don't really know the answer to your second question, so I'm going to ponder that for a second while I answer the first. I don't think we have evidence necessarily. This has only been a few years, right? So clinical trials take a while. I don't think we have evidence that says this will make us faster and develop products more quickly in the way that I described. What it has done is we've killed projects earlier. So in some sense, that's going to cycle back. And the people that were previously working on something that would have taken another 2 years before it failed, I think we can fail faster. Crystal Pepsi, can Crystal Pepsi ever take off, I guess is the way I'd frame that. Maybe. I mean, you can't ever say never, but I guess I'm the sort of person who believes that you do as much as you can to inform your choices, and that's the best way to proceed. Will you be surprised sometimes, and will you be wrong sometimes? Probably. But are you better off being wrong in a smaller percentage of cases than if you just continued without the evidence? That's sort of the trade-off I see, I guess. Okay, thank you.